Hello, and a very good morning and good afternoon to all of you. And thank you for joining us today for our webinar on advancing national action plans on AMR during the health financing challenges. We, on the behalf of South Center, we are very thrilled to have you on board with us. I am Dr. Afrina Shamir, and I'm going to moderate today's session. As we all know about the national action plans on AMR, they are in the implementation in various countries, and they are on the strategic priorities on the national agenda as well. But we have seen the challenges during the implementation, and we have designed this webinar to discuss with all of you the challenges that the countries they are facing, either through the domestic financing issues or the global financing issues. So we are very happy to have a very good group of experts with us in this webinar, and we are going to have a good discussion with all of you. And first, I would like to invite Dr. Viviana Muniz. She is the head program at the South Center Geneva, and she has been doing a lot of work in the field of AMR for quite a long time. Thank you, Dr. Viviana, and I invite you for your welcome remarks for this session.
Thank you very much, Dr. Afrina Shassan, and thank you everyone here, panelists joining us. Just a quick welcome from the South Center to say we're an intergovernmental organization of developing countries, and part of our role in the AMR space is to support all the efforts that are being done, in particular in developing countries towards implementation of national action plans on AMR and overall, the global challenge that there is on antimicrobial resistance. So we hope that all of you will learn along us on this event today. And thank you again to the panelists. And with that, I'll just hand back to you, Afrinesh.
Thank you, Viviana. And with this, we move towards our agenda for today. We are going to have two short presentations from two countries. We are going to hear from them about the implementation of their national action plans on AMR within their countries. And this will be followed by our panel discussion with a group of panelists. So first, I would like, with our first presentation for today, which is from Ghana, I would like to introduce Mr. Xavier from Ministry of Health, Ghana. And he is the acting director of pharmaceutical services at the Ministry of Health at Ghana. And he is fellow of the Ghana College of Pharmacists, and he holds a master's degree in public health as well, with specialization in health policy planning and management. And he heads the Ghana Antimicrobial Resistance Coordinating Secretariat at the Ministry of Health, and which is implementing the National Action Plan on AMR at Ghana. So very happy to have you, sir, here with us, and we would like to hear your thoughts on the implementation of AMR. So over to you.
Thank you very much. As you said, my name is Xavier Yevuche, the AMR Secretariat of Ministry of Health, Ghana. This is a great opportunity for us to share what we'll be doing and to learn from others too, because this battle is for everyone. And if we don't learn from others, we may not be able to win the battle against resistance. So thank you very much for the opportunity once again. And to do that, I want to just say that I will give some brief introductions and the policy, the progress of implementation, the challenges align with the topic of the discussion, that advancing NAPs on AMR amidst health financing challenges. The Ministry of Health actually identified this problem some years back, and we'll be working towards this. And before around 2012, we actually started developing policy and the National Action Plan to be able to fight this in one health approach. Currently, there are 4 sector ministries that are involved in the implementation of the National Action Plan. The Ministry of Health being the sector lead, the Ministry of Food and Agriculture, Ministry of Environment, Science and Technology, and the Ministry of Fisheries and Aquaculture Development. And we also have other collaborators, partners on board that are helping us to implement the policy. The policy was launched by the President of Ghana, and that shows the high political interest in solving the problem, because data we presented before them in 2017 shows clearly that we need to have a coordinated national effort in fighting AMR in Ghana. The overall goal of the policy is to improve and sustain the health of the population, as well as enhancing food security, ensuring responsible use and access to safe, effective, and affordable antimicrobials of good quality to slow the emergence of resistant microbes and prevent the spread of resistant infections in One Health approach. So that's why we have all the sectors on board. We have our National Action Plan that has expired now, and some of the outstanding activities are being implemented whilst we develop too. We have about 143 interventions in the old NAP, and we have done end-term assessment on the implementation so far. And by the end of 2021, out of the 143 activities or intervention in the NAP, we have implemented 70% of them. From 2022 to date, we have identified those activities or interventions that we need to continue implementing, because some of them are not one-time activity or intervention. We'll continue to do them till we all leave this world and another generation comes on board. The AMR MPTF projects, USAID, WHO, COICA, Fleming funds are actually supporting the implementation of those outstanding activities in NAP1. As a governance structure, we have the Interministerial Committee, that's the higher decision-making body for AMR National Action Plan implementation. We have the supporting AMR multi-stakeholder platform, which other countries call AMRCC. We have partners on board. We have civil society organizations, academia, and all other institutions. The traditional ruler, the queen mothers and the kings and the chiefs are also on board. All these activities coordinated at the AMR secretariats of the Ministry of Health. Let me just share some progress we've made so far, or the status. If you give me the whole day on what we have done, it will not be enough for me. So selecting some few just to share with you. For awareness creation, which is one of the key areas that we have to continue creating till the world come to an end, we have made a lot of progress. We have engaged the civil society organizations, trained them, and that these days they also go to the communities, the rural areas, to talk about antimicrobial resistance and practices that lead to the development of resistance. We have engaged the media, trained them how to communicate the information on resistance, and out of the 10 original regions, we have done 9 out of 10. And then later on, politically, the regions were split, and now we have 16 regions. So we continue to engage more and more annually when we had a chance. Through the Awareness Week celebrations, we've engaged in a lot of awareness creation. Food Safety Week, we also take advantage to talk about AMR all the time, all the years. The International Infection Prevention Week, we also use the opportunity to talk about it. And then we also engage professional bodies, the health professional bodies, at their annual AGM, general meetings. And then also, specifically the pharmacists in Ghana, that's the Pharmaceutical Society of Ghana, they have actually levied the members, over 5,000 members, to be able to raise some fund to do engagement of the communities. And it's one of the powerful engagement platforms we have, because during our celebration, they are able to reach all districts in the country. The pharmacists in every region our districts are involved in awareness creation in the churches, in the mosques, market squares, lorry stations, and so on. So it's a very powerful platform where messages are actually sent out. We also engage some of the training institutions on AMR. Just to show some of the, during the COVID, we were still doing the training of media practitioners. And after the COVID, we continue to do that. And then on the streets, during the world celebration, is a major issues across the country. So just to show some few pictures of what has been done in one of the regions, Koforidua to be specific. That is for the human health. For animal health, we have actually undertaken knowledge, attitude, and practice studies in poultry and piggery to understand what informed their practices and develop tailored interventions to curb the menace. We have also used the farmer field schools in the poultry rearing region. Predominantly, we talk about Doma. That's a country, one of the districts where we have a lot of poultry farms, and we have engaged them on the farmer field school training, and that has given us a good result where we have seen drastic reduction in antimicrobial use on the farms and a better yield in terms of the quality of the meat and also the quality of the egg they produce. And it has even given them the opportunity to sell their eggs and meat chickens before those who are not using the farmer field school concept. On the issue of surveillance, this is the surveillance structure of Ghana, and all the sectors, the human health, animal health, the fisheries and aquaculture, and environment. So we have data, AMR data, antimicrobial residues being monitored, and all these data are collated at the national level at the AMR secretariats and analyzed. For Ghana, we will be launching our first annual AMR report, and that will be used as an advocacy tool to engage political class and the policymakers. Because of high attritions, more fresh policymakers are coming on board. So we need to engage them with these annual reports so that we can get some funding or justification why they should allocate more fund for AMR activities in Ghana. We are also doing the ESBL E. coli tricycle project that is giving us the picture what is happening in human, animal, and the environment. We are also monitoring the antimicrobial use on poultry farms, fisheries, and piggery, using the digital collection tools platform. And that is giving us some picture to inform us how we communicate the issue of consumption to the practitioners. And then the Environmental Protection Agency, EPA, they also conduct surveillance through monitoring institutions such as the pharmaceutical industries, and then the hospitals, effluent, waste management, to give us evidence on what is happening with respect to antimicrobial residues in the effluent that is being discharged into the environment, and whether our treatment plants at these factories are actually helping us to solve the issue. We also have labs through the support of the Fleming Fund. We now increase our surveillance site to 14 for human, and animal health to 3 more have been added. And so our data point is also increasing year by year. We are also monitoring consumption data for the first time at the port of entry. So we have 1 year data for 2023, and 2024 is being collated now, so that we'll be able to give the picture of consumption in terms of imports and local manufacture. We have our national antibiogram for 2021, 2022, 2023 available. We are now working on the 2024 data, and this data has been analyzed. That's why the report is coming up very soon. And the picture we are seeing is going to inform the National Medicine Selection Committee in selecting appropriate antibiotics to treat some of the infections that we are having high resistance to. That process is ongoing, and we know that the report is going to be very useful to us. Just to share this graph with you, the black culture isolate for Klebsiella, which is one of the bacteria that is troubling us. Our standard treatment that currently we are losing the battle between Klebsiella and ceftriaxone for bloodstream infections because of high resistance. And this picture is coming from our national surveillance system. And so the phenomenon we are seeing now, seeing more consumption of meropenem and amicus in the aminoglycoside, the data actually support it because they have relatively lower resistance level. And so this graph will be useful for the medicine selection committee in selecting appropriate antibiotics. The same thing applies to E. coli for bloodstream infections, as we can see from the graph, that we are gradually losing the battle between E. coli and some of the antibiotics that we currently have on the standard treatment guideline that is under revision. For urinary tract infections, data from 2017 to 2021 shows that E. coli is the most commonly found pathogen in urine. And the resistant pattern that we are observing is not good enough. Looking at the gender and equity issues on the analysis of the data, we have realized that for pregnant women, the E. coli that is identified, there's high resistance. And this information is very, very useful for us in the standard treatment guideline revision. Our first line of choice for men with E. coli infection, urinary tract infection, is ciprofloxacin, but they look at the resistant pattern, 62%. And so that's why we have to look at the coming back of nitrofurantoin and fosfomycin if necessary. And so all these are under consideration by the National Medicine Selection Committee. In the implementation of the National Action Plan, we have done some analysis, and these are the major gaps and the challenges. At the micro level, we have inadequate commitment and dedication from the interministerial level. It's difficult to get the political class sometimes to come and sit at table, but we always have means of solving that by engaging the chief directors, permanent secretaries of the ministries, so that we can continue implementation if the political class will not attend the meetings. The major one is the issue of funding, the inadequate funding from the government of Ghana. And this is an issue. And so we are of the view that we need to get economic data, which is currently under study, so that we'll be able to convince the Ministry of Finance to state the reason why there is the need to allocate funding. We have actually talked about mainstreaming National Action Plan into sector-wide action plan, so that anytime there's budget approval, we'll have some funding to implement our National Action Plan at the other ministry and collaborators level. To be frank, last year, we did that mainstreaming, and the Ministry of Health actually gave us some money, funding, to be able to review the standard treatment guideline based on the resistant pattern that we are looking at. So I think the mainstreaming is working for Ghana very much. And then also there's the need to advocate for the partners that are working with us to look at the areas of financing AMR in the country, and then to actually avoid these silos of vertical programming when it comes to AMR, with more focus on tuberculosis, malaria, and so on. This is a broader picture, so that we can also benefit from the AMR sector, can also benefit from the funding that is being made available to the country. So as a next step, to continue to have broader stakeholders engagement to develop the NAP2, which is under, that's what we are doing now. And then also to encourage mainstreaming of National Action Plan into government agencies' sector plan, to be able to increase chances of governmental support in terms of funding. And then also to encourage the One Health approach in the implementation, because we realize that it's actually helping us in achieving a lot of work that we have done. We have seen drastic reduction in antimicrobial misuse of antibiotic in hospital settings because of the antimicrobial stewardship program. Thank you very much for the opportunity, and I stand by for any question. Thank you.
Thank you so much, Mr. Xavier. And it is really interesting and eye-opener for us to see such a great progress on AMR implementation in Ghana. And as you say, the end of assessment report is about 70% of the targets that you have identified, they are accomplished. So that is a big achievement. And definitely we have some questions for you. I guess we can move toward next presenter for today, and then we can have a combined discussion with you and Dr. Andre. So thank you so much. And now we move to our next presenter for today, Dr. Andre Abreu. He is from Brazil, and he is the coordinator for the National Action Plan on AMR with the Ministry of Health at Brazil. And he has been doing a lot in the field of AMR, and it's a pleasure to have him here with us in this session. So over to Dr. Andre for his presentation on the NAP implementation in Brazil.
Thank you, Finish. I will share my, just a moment. Can you hear can you see my screen?
Yes, we can see.
Thank you again. Thank you for the South Center for having me here, and congratulations for the great work on Ghana, Dr. Sewa. So I did a very brief presentation for the sake of our time, and I'm any doubt I can explain later. So just a contextualization of Brazil. So we are the largest country of the South America, and very complex, 211 million inhabitants and 5.5 thousand municipalities, distributed in 5 regions, very diverse, very different, and very complex to deal. We are a upper middle income country, and one of the world's largest livestock, poultry, and grain producers. And it's so AMR has a huge impact in human and animal health in Brazil. Our health systems is a free health system, free access, and covers 100% of our municipalities. And we have a history of AMR sensitive initiatives since the 70s, and when we established our national immunization program, and that distribute around 300 million doses of vaccines every year. And we have a strong national laboratory network that was established in the 70s, the same way, and our essential medicine list. And so it's the same in the same period. In the 80s, we established this system. There's a unified health system in Brazil, and we established a lot of strategic health programs, as the program, the HIV, IPC program, and TB, and so on. And in the 90s, we have our National Regulatory Agency, our Anvisa. It brings a lot of quality for the medicines in the country. And in the 2000, we established some national strategies to monitor AMR and institutionalize it. And in the 2010, we started the control of antibiotics prescription and sales in the country. And in 2018, we launched our first national action plan on AMR after around 2 years of discussion and engagement of key stakeholders on society and the technical team. And we thought that good part of the work were done with the plan ready. And so it was not the reality. The burden of AMR in Brazil, this is the data from the Global Burden Disease. So AMR is a third cause of deaths in the country. The AMR use This data is from the COVID period. We are updating this information, but we have 52% of access use and 47% of aware. 80% of the prescriptions are for physicians, 15% from dentists, and 1.7% from veterinarians. And these are our NAP that covers the period of 2018, 2022, and we are calling 2022 plus 2 because we are now discussing our new NAP for 2025, 2030. And we followed the Global Action Plan with 5 strategic objectives and with One Health approach. This plan encompasses the animal health sector and the IPC sector in Brazil. More. So here I would like to highlight some progress that we did during this period. And so a lot of guidelines, a lot of webinars and free trainings for health professionals. We did our epidemiological reports on AMR, and not only about the bacterial, but about including other disease as gonorrhea, Hansen disease, and TB. We strengthened in funding the research and surveillance, both with domestic and with international funding, in thanks to our colleagues from CDC, PAHO, and American Microbiology Society, that we foster the surveillance and research in the country. We launched our national IPC program. We updated and with a lot of trainings for the hospitals. We increased the access to safe water and sanitation, but we still have a lot to do. And we recovered the vaccines coverage, especially in children under 5 years old. We adopted the AWARE classification on our national essential list, medicine list since 2022. We strengthened our national concept for rational use of medicines. We established a reverse logic of medicines. We avoid a lot of medicines in antibiotics, including this, to be deposited on the environment. And we include the new drugs for TB-DR treatment for free treatment. And we phase out the use of 12 antibiotics in the animal health sector. And the last objective, strategic objective, we only established the technical working group on AMR. And in the last year, we established our One Health National Committee. So our implementation status is partially implemented, especially because we don't have the funding, dedicated funding for AMR in the country. We have funding for AMR sensitive intervention as immunologicals, other treatments, access to health service, sanitation, hygiene, but for the implementation of the plan, we don't have any dedicated funding. It's a problem in Brazil. It's a problem in the majority of the countries. But other key point that we need to address is about the governance, political and community engagement. This is so important as the funding, because the governance, monitoring and evaluation priority of actions. It all leads to a good discussion with the political and the community. And this brings the funding, domestic funding, as a priority. Other point in the low and middle income countries is to include the AMR in a very complex agenda and very complex epidemiological context that we have. As an example, in Brazil, and last year we have our biggest arbovirus outbreak in the country. So include AMR in this agenda is not so easy. It's not so easy to make this happen. And so adapting the AMR narrative and communication to the local context. Sometimes the discussion around AMR tends to be focusing on push and pull incentives and the production of new antibiotics. It's so far from our reality. And in some cases, it's very difficult to put this problem on the table to discuss with our managers or decision makers. So bring AMR to our reality. It's key to move forward with this agenda in low and middle income countries. We understand that the new antibiotics is part of our necessity and part of our reality, but we need to talk about our problems. Other key point is the integration with the strategic programs in Brazil or in our countries, taking account the complexity, the epidemiological diversity. We need to be intervening with these programs to move forward with our agenda. Sustainable and domestic funding for AMR specific interventions. It's our key point today. And despite we have a free access to health service, we still need to understand the access to medicines, the access to antibiotics in the country. And the narrative, the AMR narrative, tends to understand that present AMR as a problem of access. And in the majority of countries, we still have the problem of access to new drugs, access to antibiotics at all. And as the way forward, especially because of the high-level meeting, the political declaration, we are committed with a lot of points on the high-level meeting, on the political declaration. But we need to change the way we are dealing with AMR in our countries. Without a very strong governance and a local and regional governance tools, I don't see a way to change the scenario that we're living in the short run. We need to strengthen the integration with countries. We need to have local plans and regional plans. We need to connect each other and share information. Optimize the funding allocation. We have in scenario of the scarcity of funding, we need to optimize what we have, especially when the donors don't take in account the national action plans. There's a lot of good projects that are inspired by the plan, but not committed with the plan. We need to bring this kind of commitment to reduce the burden on the government and to foster the implementation of the plans. Capacity building is not only about the technical side. We need to include the strengthening of local leadership. We need to have more leaders to discuss, to take decision, to fight for AMR in the countries. And so we need to foster the implementation gaps. We have the commitment to, until 2030, all countries with their plan developed and implemented. We need to think how we're going to achieve this goal without understand why those countries do not implement their plans. I don't see a way to reach this goal. Support and promote the data and the knowledge sharing. It's very important to learn, as we are doing here, learning with Ghana and how they did, what are their struggles on AMR, and what we can do together. And update the global monitoring tools. One thing sorry, especially for local low and middle income countries, we are using the tracks survey, but we are using the same scale to measure totally different contexts. We are comparing high income countries with low income countries. We are comparing different situations, and we sometimes it's not helping the way we need to deal or how we can improve the implementation of the plans. And for the list, we change a little, we change a lot of the narrative from how to deal with AMR. In the first period, we are discussing about the antibiotics and the resistant mechanism. And in the last years, we included the survival task force, we included youth, we included other audience. And we start to think and bring to the light the importance of the people-centered approach to tackle AMR. We need to think, we need to work for the people needs and how we're gonna tackle it. And that's it. Thank you. Finished.
Thank you, Dr. Andre. Very interesting, and I can totally relate to the problems and the challenges that you've been mentioning. So, just a quick question with you and Dr. Xavier, if he's around. So, I keep on hearing about that issue of the funding. So, in particularly from Dr. Xavier, that you were mentioning that we have to generate a case so that the local government can raise the funding. This takes me back towards that very recent political declaration Dr. Andre was also mentioning, and it keeps on highlighting to raise the financial case for the LMICs. So, how do you see that push from that ANGA declaration? Does it going to have any impact on the local government? And how do you see the partners they are contributing towards the funding?
Thank you very much for that question. We have realized that the political class, for instance, the Minister for Finance, is not a scientist. He's a finance person, and he has so many issues to allocate funding. So it is his understanding of the burden of the phenomenon of AMR that will make a case for us. We saw a typical example last 2 years when the budget was read. In defending the budget, we pushed the issue of AMR. And the Deputy Minister for Finance asked, what is that issue called AMR? And it was explained with some economic figures that we have, and the number of deaths coming from there, and the effect on the national health insurance, the sustainability. And then they said, well, include it and then do some allocation. That is why we have some allocation practicing and using to implement our national action plan. Though there are political declarations at the UNGA, that is not known to the political class. Yes. For instance, those who attended the meeting last year, there are not people in government as we speak. There's a change of government. So it is the local data that we can use to advocate why there's the need to add. And then some of the evidence are very critical. We know some bacteria that is affecting cash crop like mango plant and reducing the yield. And if we have been exporting mango, and that picture is painted to government, that because of resistance, we are not able to treat that infection in the mango plant and it's affecting our yield, then it is right for them to invest in controlling resistance in the plant sector too. So that's why we are going with the One Health approach, all the data that we have to be able to meet them. Thank you.
Thank you. Totally agree with you, Dr. Xavier. The understanding at different levels needs to be generated to have a very good case generation for the funding. So, Dr. Andrea, quick question from your side as well, to you as well. You have mentioned about one of the strategies, global change in the global monitoring tools. And this takes me back towards that MNE framework, the local national action plan and their frameworks. How do you see that the targets they are keep on being identified at the global level that you have to do this and this, but how do you see the Brazil is working towards that identifying the targets in their MNE framework?
So, Pranish, we are working with the targets in our new national action plan. Despite some of our partners still have some doubts on how we will achieve it, because it's tricky. We all agree on targets because we have to be objective. We need to have some goals. Out of it, we just doing and it's an endless road. Okay. But we put our data, we put our targets to reduce the antimicrobial use. We put our data to reduce the burden of disease in Brazil. But first, we will work on understanding better what we are having in our country. It's the main thing to set if it's achievable or not. And one thing that we heard a lot in our country, and it's main of decision makers, main of people who deal with the financing don't understand that AMR is a problem for low and middle income countries because of this narrative. We keep talking about antibiotics, new antibiotics that spend billions of dollars, and we are not talking about how the AMR is affecting our population. So we are working on achievable targets and feasible in that is connecting with our reality. That's the way. The ownership, the government ownership, so the country ownership, the leadership that we need to develop in the countries to discuss what we need.
Thank you. Thank you so much. Yeah, I totally agree. Very right thought that a multi-sectoral approach and a multi-dimensional approach needs to be done to control the issue of AMR. And I thank both of my presenters, Dr. Xavier and Dr. Andre. And we move towards next part of our presentation for today, webinar for today. And we have our panel discussion now, and we have a esteemed group of panelists with us. Very own Dr. Sabia Isaac is here. She is the she's working in the South African Research Chair in antibiotic resistance and One Health and professor in the pharmaceutical sciences at University of KwaZulu-Natal in South Africa. She is the co-chair for quadripartite technical working group and a member of the STAG AMR as well. She has been engaged with many big organizations like ICARS, CARBEX, Fleming Fund. Thank you, Dr. Sabiha, for joining us today. And our next panelist for today is Dr. Rahila Ahmed. She is a Reader Associate Professor in Health Systems at Cities St. George's, University of London. And she is a Research Strategy Advisor at the Fleming Initiative. She has been working and supporting the UK government and in the Fleming Fund Policy Fellows program. And she has been doing a lot at the health management and leadership and innovation and change management. Thank you, Dr. Rahila, for joining us. And our third panelist is Dr. Viviana. She is the head programs at the South Center and contributing for the last 20 years in the field of AMR. So I would like to have some questions with you, all of you, one by one. So we can begin with Dr. Viviana, with you first. And we would like to hear your thoughts that how have been the international funding, the global partnerships and initiatives they support the National Action Plan on AMR implementation, and how do you suggest that countries can take to access and leverage these resources?
Thanks a lot, Afrinesh, and first of all, also to point to the previous two presentations, which are really enlightening. And again, just to highlight the importance of having that development perspective to really understand how do we take into account the specificities of the context where we want the AMR interventions to be made. So addressing your question, I mean, just to take a step back before looking at what the international specific focused financial initiatives have done in AMR, I think it's important that we recognize that also AMR is part of the broader health financing challenge. And overall, it is a development challenge. We know that of the Sustainable Development Agenda goals overall, 17 are on track of all the SDGs. Of all the different indicators. And so there's a call, like this year, there will be an international development financing conference again to highlight the point that we need to mobilize financing at scale overall for all the whole development financing gap, which is estimated at 4.2 trillion annually, just to meet those gaps and in line with the SDGs. So that's the context where we get into health financing and then the specific AMR financing. Just in the general health gap, we know there's around 4.5 billion people that are not covered by essential health services. So when we are looking at the particular question of international funding on AMR, it is still a drop in the water of this range of finance mobilization that we need. So of course, the international support that can be given in this area is very important, but it's meant to be complementary to, of course, what should be domestic financing mobilization. And part of the solutions for domestic mobilization are going to be linked again to the kind of mechanisms that countries have as well to have more financing. So I won't go into that, but just to mention that issues including on how do we have a fair taxation for corporations that operate globally, and for example, the UN Convention that's being worked on that right now. These are also very important issues that perhaps our AMR focused community does not discuss as much. But it is as relevant as looking at, particulars focused domestic or international financing on AMR. So in terms of the international financing, I would just say that there has been direct financing coming from, for example, the multilateral development banks. Some have programs that can fund directly country health-specific issues such as AMR, so we with World Bank programs. Then there is indirect sources, for example, the Pandemic Fund that has now also given specific AMR projects at country level, and this has focused a lot on laboratory and surveillance system strengthening. We have a significant, and I think this has been one of the more long-standing support has been from the United Kingdom's Fleming Fund, with the country grants in particular supporting both surveillance and laboratory system strengthening, and I think more recently also extending to other areas. And importantly, not just in human health, but also extending now for strengthening the animal health systems and in the environment now. Interesting, we've seen the Global Fund with as part of their whole strength of focusing overall in health system strengthening overall in countries, that they have introduced the line as well for support and AMR initiatives. So that's a very good entry for countries that already operate within the scope of global fund funding, and that also are encouraged to find sustainable ways to move out of that global fund funding for specific areas after a period of time, that they can incorporate AMR specific interventions as part of the use of the global fund funding. Then there are different regional and bilateral initiatives that have been supporting on AMR. I won't go into details, but I'm sure some other panelists perhaps will touch more about the impact, for example, the reduction of some of those bilateral funding, even just on the technical support as well. For example, the United States, the CDC, so the Center for Disease Control, Infection Control Branch, and USAID that have been really important as well in different countries, and what the impacts of the cuts or the dismantling in the US might have for developing countries, in particular in the area of AMR. We still don't know, but significantly it's already having, deep impacts. And the other area I would just like to highlight where it's international financing has been really important, I think, is for the international agencies that provide so much of the technical assistance to developing countries, which of course includes the World Health Organization. So it's important at this moment also that we promote that support directly of the core funding, as well as particularly targeted funding for AMR by more funders, and specifically now that the World Health Organization will have the major source of funding reduced from the US deciding to leave the World Health Organization, and as well as to other important quadripartite agencies, the FAO, WOA, and UNEP, but as well as the other players that are really important for AMR that are outside the quadripartite, but just as important, for example, for delivery of essential antibiotics and other medicines, UNESCO, UNICEF, others that can be involved in different areas of AMR interventions. They also need to be involved, and that is mentioned importantly in the UN declaration of last year, to have more synergies with these other partners. So as international finance is decreased, we really need to find more synergies between these international funders. I think really important to keep in mind the message that Andre was mentioning about ensuring also that it is supporting the national action plans as member states, as countries have designed them, with the prioritization that they have done, and then come in as partners to support that work. Because sometimes while project level might be very useful, sometimes it might focus not necessarily on the key first priorities of the country. So, or it might incentivize to create more of an AMR vertical sort of system via what some countries, as we heard as from the two country experiences in Ghana and Brazil, that they're also seeking to integrate AMR more closely with other programs and other initiatives, not just as a vertical approach to AMR. So these links, for example, to pandemic preparedness, as well as to the overall effort to advance in universal health coverage and primary health care, to introduce AMR interventions directly that are funded with those links, is also important in that getting the international financing better aligned to where the core needs of strengthening health systems and then AMR interventions can help. So I think I'll stop there to make sure that we have more time for further discussion. Thank you.
Thank you. Thank you, Viviana, for a very detailed description on the different models that are existing, and how can we leverage on these mechanisms in the current challenge that we are facing right now. So this makes me to move towards Dr. Sabiha. Dr. Sabiha, with this current situation, that how do you look at the current financing landscape, and particularly for AMR, and do you think is it sustainable?
Sure. So many of you on the call today may be aware of the AMR External Funding Resource Inventory for research and NAP funding, National Action Plan funding, across all sectors compiled by the quadripartite. Viviana actually mentioned a number of those funders in her presentation. So if we look at the funding specifically for National Action Plan implementation, on the global level, we have high-income country contributions to the Multi-Partner Trust Fund, or the MPTF as we know it, which is managed by the quadripartite. Now, the MPTF aims to raise $100 million to facilitate National Action Plan implementation in low and middle income countries, as was stated in the 2024 political declaration on AMR. Still at the global level, the World Bank has launched its AMR framework for action and is working with countries on NAP implementation, drawing on the quadripartite tools and guidelines. Also on the global level, we have the International Center for AMR Solutions, ICAS, that works with country governments and researchers to implement national action plans using intervention and implementation research. ICAS swims in the same funding pool as the MPTF. There's also the Fleming Fund that focuses specifically on the surveillance component of the National Action Plan, but allocations to the fund have progressively dwindled over the years. So that's a sort of an overview of what's specifically for NAP implementation at the global level. If we look at the regional level, we have individual quadripartite organizations. They have modest funds to pilot small tests of change for projects in the for regional learnings. At the national level, we know, and from the presentations from Ghana and Brazil, there are a very small fraction of countries have allocated domestic budgets for NAP implementation. The vast majority of these countries that have done so are high-income countries, and this is all from the latest TRACS report. So, unfortunately, Afinish, the writing is on the wall regarding Global North funding. The US has instituted a moratorium on external aid, and the geopolitical crisis in Europe has required the EU to revise its national and regional budgets towards greater defense funding, for example. So LMICs can no longer rely on high-income contributions to globally managed funds to address AMR. And I don't need to tell this audience what the costs of inaction on AMR will be. So we know there is an escalating public One Health crisis with extensive health, economic, and societal implications. And you know the stats. I'm going to stop there because I know that we're going to speak a little bit about, so what do we do later on in the conversation. So I'll stop there. Thank you.
Thank you, Dr. Sabiha, for highlighting the other institutions and how the funding can be mobilized from the different resources as well. This takes me to Dr. Rahila. Dr. Rahila, being a system specialist, we would like to hear from you. What evidence can we generate to help identify what approaches are progressing the AMR NAP targets, and how do you see them under the context of the system efficiencies?
Thank you so much. Thank you for inviting me and the excellent talks. So I think that the talks have already set the scene in terms of this needs to be a systems approach. I will be focusing predominantly on health systems, simply because I'm staying in my lane in terms of my expertise, and want to just talk about three key areas that sit under the sort of integrated care system. So those efficiencies. So first, starting with efficiencies, we've heard about the donor funding. Whether there's donor funding or not, the national health systems, in whatever model they follow, whether they're single payer, a welfare system, all have to be efficient. We have to be efficient as a health system. We have to be there for future responses to future threats, and that's about creating economies. So if we look at integrated care systems, so the healthcare system, there are three main aspects I just want to touch upon. And I think Xavier and Andre both did actually touch upon that in their talks. And this is really a focus of the Fleming Initiative work that we're carrying out here in the UK, which is going to be a huge and global effort with collaboration with WHO and other partners. The first one is to look at patient pathways. So when we're looking at patient pathways across community, primary and secondary and tertiary care, where can we have efficiencies there? And to support that, really about where is the most efficient care? Do people need to be in hospital? We apart from putting patients at risk, by being in hospital, do they need to be there? Can care be considered elsewhere? So those efficiencies. We all talk about the revolving door, so patients coming back in to care, whether it's primary or secondary or tertiary care, and preventing that. So those levels of efficiencies. The second one is data linkage, and that links to the monitoring evaluation. So if we can have systems where we have good data linkage across the whole health economy, across primary, secondary, tertiary, but also long-term care where that exists in a formalized way. So if we can have data linkage, we can have better surveillance, we can have better intelligence, and we can have more efficient systems. And then the third one, which Xavier did talk about in the context of Ghana, is that public and societal ownership. So this is not public and patient involvement. This is not a campaign. This is about the public owning and driving change. I'm going to just cite Wanless, the economist, who, more than 25 years ago, he set out an eloquent modeling of what the economic scenario would be if we had a partially engaged public in their health. So not just for AMR, but health. And what that looked like in terms of the economics. So not just health outcomes, but the economics associated with a healthy population, productivity. And he modeled a fully engaged scenario. And I think we really need to start thinking about that. The fully engaged scenario is the most cost-effective and cost-efficient way in which any country can achieve efficiency. So what we might want to do is think about what that looks like for AMR, so what does that look like in terms of being fully engaged and being very authentic and true to that? So we definitely have the person-centered approach framework from the WHO, which is excellent. We talk about engagement. We have the World Antibiotic Awareness Weeks, all of those things. But this needs to be something that is driven by the public and owned by the public. And we've seen that. We've seen successes in other areas. We've seen that in HIV in South Africa. We've seen how that happens. We've seen that in TB and India. So when that happens, we do get that driven from the public, because the workforce, we know globally, is limited. It's going to become more limited. It's going to be stretched. So it's not engagement through the workforce and through academics and through institutions. It's direct with the public. So that's the 3 points in terms of the efficiencies. I think you asked about the evidence. I can talk about that in the next round, or should I carry on?
Yeah, you can share your thoughts right now. Yeah,
let's do it. Yeah, because we're on a time ticking time there now. So really, the other part of it, as you say, what the evidence, and it's what Andre was saying about needing better or more sophisticated monitoring and evaluation. So we have the tracks system, we have some level of comparison, but it's really what Sabiha is saying there about the implementation side. So we've got the support for implementation. How do we now compare and track how implementation is in different countries? What kind of bucket within that implementation is working? And why is it working in different contexts? So having that level of comparison, that's the evidence we need, along with the value proposition that comes with it, which Xavier was talking about. So if we're able to combine those two and have methodologies to bring those together, which is exactly what we're working on at the Fleming Initiative. This is the new work that we're doing. And so glad to hear that this is kind of the ask as well from our panel today. I'm just trying to get rid of something that's popped up. And for that, we're looking at regional comparisons, not to say we have to do things the same way, but to be able to at least compare and say, why is it working this way? So we have got a framework where we can then sort of plug into the tracks, the global burden of AMR, and also the antimicrobial usage data, so as outputs. So if we're able to look at that, we think that that's where the evidence need is, to bring that middle bit in, and then for countries to be able to look retrospectively back longitudinally to say what they've been doing, and then to be able to look at countries of similar economy and see what they're doing, and also look at countries of similar geography, so regionally, what they've been doing. And that would be very relevant in terms of the WHO South Centre, but also being open to learn from countries from other regions and other economies, because we have a lot to learn across that. And we one sort of point in terms of terminology, if we can really think about low and middle income settings rather than talk about developing countries, then we may get that level of comparison that we really need. I'll stop there because I know there's another set of questions. Thank you, Dr. Freenish.
Thank you, Rahila, for a very good understanding, a deep understanding into the system, that what are the factors, determinants, and the way you look at the things that will definitely help the people to understand the challenge and to find for a better solution. Thanks for your good explanation. So I go back towards Dr. Viviana. Viviana, just a quick question to you. In the current scenario of economic sanctions, how do you see it will affect the LMIC's ability to fund the AMR related activities themselves? And it will, do you think it will overall impact all this vulnerable population?
Thanks, Afrinish. I'll refer specifically to unilateral coercive measures. So these are measures that in the United Nations system already have been determined as to be in violation of the Charter and numerous instruments, including human rights instruments. So we had more recently also last year a new resolution from the Human Rights Council as well, which mentions and calls again on states to terminate any unilateral coercive measures, which can include trade or other financial sort of measures that parties impose unilaterally. So just to say, these should not be measures that should be done already in accordance to international law. And of course, they have a very significant impact on health and the ability of countries to respond and for countries to follow on those obligations they have to support the right to health for all. So in AMR, of course, that has an impact too, in particular also for proper stewardship, but also access to antimicrobials. And some countries that have direct studies, I won't go into that, but there has been several studies also from the specific UHACR that has had a particular commissioner looking at the issue. So we see clear examples of that impact in countries such as Cuba and Iran. So deeply, deeply affected by the measures.
Thank you, Viviana. Yeah, I totally agree with you. And this takes me towards almost our last question for Dr. Sabia. Very tough question, but for you as well. How do you suggest that these financial challenges that we are seeing, they can be best addressed? And what could be the possible financial or particularly resource allocation approaches that you can suggest that can help the countries to go for the NAP implementation?
Thank you again, Dr. Afrinish. So let me say again that the existing financial model where low and middle income countries rely on global north contributions to globally managed funds is at best unreliable at this time. So on the global level, maybe we should start focusing on leveraging cognate financing sources such as financing for climate change, pandemic prevention, preparedness and response that was already mentioned, as well as the international health regulations, all of which are linked to AMR. According to the WHO AMR Secretariat, over 80% of the first round of pandemic fund country grants allocated by the World Bank explicitly included AMR, so 80%. And 25 countries included AMR surveillance in applications to the Global Fund under the Resilient Sustainable Systems for Health and COVID after the COVID reprogramming. So we are taking steps in the right direction. What I wanted to emphasize is that any kind of external funding should have a dedicated work package on sustainability, where the country progressively takes ownership of the NAP implementation and financing from domestic sources, so that AMR intervention continues after the grant ends. So we all know that everything comes to a standstill once the money is stopped. So the aspect of sustainability has to be part of the funding. It's not negotiable. At a regional level, we spoke about small tests of change and small funding. I think regional quadripartite offices should undertake a knowledge synthesis exercise to identify good practices, barriers and enablers for NAP implementation, such that the countries can adopt tried and trusted evidence-based interventions that are going to be assured of a return on investment. And I think Dr. Rahila mentioned something of that sort as well. Twinning high-income and low-income countries at a global and regional level for mutual learning, capacity strengthening, and financial commitment to address AMR may be an adjunct financing model. at a national level, both Sylvia and Andre said there's no new money. And because there's no new money for a vertical AMR program. So policymakers should be innovative in repurposing domestic funds and leveraging the budgets of AMR sensitive programs, such as universal health coverage, vaccination, WASH and IPC, national drug policies, port health, biosecurity, good animal husbandry, and we can name lots more AMR specific or AMR sensitive components. When it comes to low-income countries, the big three is HIV, TB, and malaria. And we already have vertical surveillance programs, laboratory infrastructure, human resources, and all of these are in place to even address drug-resistant TB, HIV, and malaria. So why can't we leverage this to also answer the AMR questions? And in summary, AMR mitigation efforts are really contingent or dependent on diversifying financing sources, refining, optimizing, and repurposing existing financing models, and devising new and innovative sustainable models to draw both from the global and domestic financing. There are ways of doing this. We have to just get on and get it done. Thank you.
Thank you, Dr. Sabiha. Totally agree with you with the concept of sustainability. Just a quick feedback from Dr. Rahila. Her insight into the system efficiency, she has completely explained the idea that how do you see that this can help us to achieve the NAP national targets within the countries on the AMR.
So if we look at it from that integrated care system model, there are countries, unfortunately they are all high income countries, so I'm aware of well the forum in which we are speaking, but if we look at New Zealand and Australia, they have far progressed in terms of having integrated care models, and there is evidence to show that. Now the question that you ask, I cannot sit here and say that we have the evidence that an integrated care model has better AMR and IPC outcomes. We don't have that evidence, and we need to generate that evidence, and that's something that we're looking at. We have some evidence to show, and we have published on this in PLOS Medicine, to show that when AMR and AMS programs are integrated across primary, secondary, and tertiary care, they do have better efficient outcomes. But we want to look at it from the other perspective, and we do not have that evidence that if the health system model is, then as an outcome, are we getting optimal AMS and reducing AMR? So that is where the evidence is. But intuitively, and what we know from other evidence, we would think that's the case, but we do not have the evidence to sit here today and say that. But we're building that evidence. Thank you.
Yeah, sure. Thank you so much, Dr. Rahila. I think Viviana needs to, there's a good question from her. Yeah.
No question. No. Perhaps just I mean, I don't know if Rinish, if you were did you have other questions, or were we?
Yeah, with this, I think we have already come to the end of our discussion, and just a quick key question or key message that I would like to hear from all of you. Anybody would like to say anything under this challenge on the with the health financing that we are seeing? We see number of the solutions that you have proposed. We have seen some system approaches as well. So what last or key message that you want to give to our all policymakers on under this scenario? So any thoughts? Yeah, anyone would like to give the last message or key messages?
So Afrinish, may I go?
Yeah, sure.
So I think for policymakers to invest in AMR in whatever form, we have to make sort of a very compelling health case. How will AMR affect the health of the nation? We have to make a very strong economic case. How will investment in AMR really have a return in investment? We have to make a societal case. How will it affect the people living on a social level? And then also a political case. So they've all signed up to the AMR political declaration. It's now time to deliver. So if we have to make almost individual cases to make it and put them all together to say, this is why you should invest in AMR, whether it's an integrated program, which I completely support, as Rahira said, or whether there is funding. I do not advocate a standalone program, but a health case, an economic case, a societal case, and a political case for investment in AMR. Thank you.
Thank you. Very good. Thank you. Yes, Viviana.
You know, I think a key takeaway also from listening to everyone is perhaps we really need to ensure that there's that level of engagement and empowerment of the stakeholders at the country level. And so it's really important to understand that context. A single country can be very small and centralized, where, you know, things can be done one way. It can be a very large country like Brazil with a, you know, urban versus the rural areas, very different. So with that complexity, the solutions have to come from inside. And what we need is all partners to help in the prioritization process, which has to be done domestically for it to function well. And then when we have that, also the other stakeholders to be involved, including community level and others, and a lot of trust, so that there's increased transparency, including, you know, in sharing of data and progress, so that everyone feels, you know, we're building this together, and that the international community has that same view of supporting those efforts as a way to make it more sustainable and ensure that domestic resources are aligned with the overall health priorities of AMR in place there. Thanks.
Agreed. Yeah, very right. And any last thoughts by any of our speakers? And
so finish it. First, I would like to thank you, and particularly you, but also the South Center for this opportunity to discuss. It's always a pleasure to meet Sabia, and it was a pleasure to meet Alia and Viviana for the first time, and also learn with Seboa and his experience in Ghana. And one point is not all funding are available for all countries because they are restricted. So 100 million for our needs is too low. And we all know this, especially in countries like Brazil. We are middle-income countries. We are not so poor to receive some fundings, and we are not so rich to make to have our own expenses and only for domestic funds. But we need to learn how to deal with our challenges, with our capacities. And we need to strengthen our capacities. In some cases, we will need support, external support, to prove that some policies, to prove that some interventions can become a policy, a public policy in the country. For last, I would like to highlight the importance of this kind of conversation, this kind of discussion, and to bring this point, this topics, and find a way to make it better, to make it a better discussion, to make it feasible for any country. Thank you.
And thank you. I think with this, we have almost come to our end of our discussion. And I really thank to all my panelists and speakers for highlighting and for helping us to understand that what could be the possible solutions. And we have heard about the solutions within, solutions for the policymakers, how the integrated system efficiencies can help us to look deeper into the system. And it's a really enlightening discussion that we have today. And I thank all my speakers and the participants for joining us today. And we appreciate the time that you took to be with us. And we look forward to have more discussion in the future. Thank you so much.
Thank you.
Thank you all.
Thank you so much. Thank you.
Thank you.